diagnosed via routine screening. I started my screening early because I had a family history of breast cancer and various other unusual cancers. There was a shutdown during COVID, and I was delayed in diagnosis because of it, but I always had ropey breasts. So once I knew where the cancer was, I could find it, and there was probably changes in my breasts, but I had generally lumpy sort of breasts anyway, and particularly the left one where the cancer was. It was always the more metabolically active one. When I breastfed, it was the one that was the good producing side. So I wasn't under surveillance. I was just doing regular screening. I was recalled at 1 week from Breast Screen Queensland, and I chose to go to the Wesley Breast Screen Clinic to complete the diagnosis because it's all done in one day. So I managed to get an appointment within 2 days due to a cancellation. I had ultrasound, mammogram, and 6 biopsies, which found 2 tumours. Well, I'm a doctor, so I knew about estrogen and progesterone, but hormone negative and hormone positive cancers. I didn't know as much about HER2, but as it turns out, I was triple positive anyway. So I was able to just update myself a little bit on the HER2 side of it. My prognosis is good. I was ultimately diagnosed with a stage 1C. I was a hair's breadth from a stage 2 cancer, so a multifocal stage 1C. It was initially excised, and then I went through treatment and opted for a bilateral mastectomy and recon. So, and my prognosis is good. I have some scans coming up because I'm now 1 year over a year post the end of Herceptin, and if they are negative scans, then I will have my port removed. In terms of surgical treatment, I knew what I wanted, so that was not discussed. My oncologist offered me lumpectomy and radiation, but I had made up my mind very quickly about that, so we didn't pursue that conversation any further. So we did a discussion about best course of treatment for me, which was dose dense AC, and then paclitaxel, and obviously the Herceptin. Primarily whether to do standard therapy or dose dense, and obviously we chose dose dense because of my age and also because of how aggressive the cancer was. So I was a grade 3 micropapillary for the most part, and then no special type for part of the rest. But yeah, I had a very high preponderance of micropapillary, and also the very high expression of HER2 and hormone receptors. So yeah. Well, initially was kill the cancer without killing me. That was the primary goal, was to achieve a cure if possible. And then in considering that, I had goals of treatment like to avoid neuropathy. So I took steps to avoid the side effects that I knew would be the most troubling to me in my life. So I froze my own hands and feet, those sorts of things. And I mean, moving forward from all of my treatment, I did end up with a lot of surgeries, and I did end up having very severe side effects. So, but I'd never got neuropathy, so that was good. But realistically, it's my goal through treatment has kind of changed to getting back to some semblance of normal life. But unfortunately, you know, my life has changed dramatically and it won't be the same as before. So my goal is to be as good as I can be. So to regain strength, to return to work safely, which I'm in the process of doing, and just to really honestly to be available for my little boy. So. Yeah, I looked at clinical trials when I was diagnosed, because obviously I do refer patients, but at the time there weren't any clinical trials that were suitable for me. And yeah, so that sort of ended that part. The absolute benefit, I was not very particularly interested in relative risk reduction. I was, what are my absolute numbers in terms of, you know, benefit and harm, and you know, what was going to give me the best chance for complete pathological response. So those were the big things, and then just so basically it was what was going to give me the best survival, and with a view to managing side effects as well as I could. No, I pretty much approach decisions in the same way. I have had to change medications on a couple of occasions due to adverse effects, but my decisions have still been pretty much consistent. You know, so if I really didn't want to have an aromatase inhibitor, I could have stopped trying because I was primarily HER2 driven, obviously. But my decisions were still, hey, I had a strongly positive estrogen receptor cancer, and therefore I'm not going to stop it because I want that survival advantage. And I know it's small, but for me it's, you know, enough to be of significance. So no, I still make my decisions much the same way. I had an initial wide local excision. I had then dose dense AC, followed by paclitaxel and Herceptin. After I had been finished a couple of months of after chemo, I had bilateral mastectomy. I had a sentinel node biopsy, obviously, for the first surgery. 2 months after I finished chemotherapy, I had a bilateral mastectomy with immediate DIEP flap reconstruction, and I've had a number of revisions and things over time with that. I had an exercise physiologist from the start, and was attending that twice a week until I became too sick from chemotherapy to continue. And I also had a physiotherapist who I was attending. After my surgeries, I then started on an aromatase inhibitor. So I started on an anastrozole. I had extreme side effects from that. I had to stop it, and I moved to exemestane, which still has side effects but less than I did before. And I have at the moment, and I've continued because I've been off work for 2 years, over 2.5 years now, really. I have had an exercise physiologist via rehab, and now I have a pain exercise physiologist to help me deal with symptoms. I had I have a counsellor, and I also have an oncology psychiatrist who I touch base with as well, plus my plastic surgeon, general surgeon, and breast and endocrine surgeon, and my oncologist, and my nurses. So. I don't necessarily need to improve anything, in terms, and all the treatment I've had now, obviously, if I get, late metastatic disease, I'm not going to know until that happens if I've had a failure of treatment. But I don't necessarily need a benefit from the treatment. I'm going with, what's best practice in terms of medications, and quite often in terms of exercise physiology and physiotherapy, all of those sorts of things, it's often been a matter of just holding my ground. So, being as fit as I can whilst being sick. So it was often aimed at maintaining or not losing too much of my function. At the moment, I'm more geared towards moving back to some more normality, but actually maintenance or minimization of loss was a little bit more the focus when I was early on in my treatment. Often it's not stuff that I can really measure very well. But if I can, if I have a treatment and I can see that it's likely to benefit me in the longer term rather than right now, or it's going to put me in a better position to achieve what I want to achieve later, that's probably how I'm measuring it. And at the moment, if I'm having a treatment, then I want to see myself slowly progressing towards being able to combat poor concentration, fatigue, and pain. So I can definitely measure those if I'm seeing an improvement. Honestly, I didn't receive a lot of information. It was something, breast cancer and treatment and potential side effects was something that I was very, very familiar with. And so I was offered information, but if I needed to find something out, I would find it myself. My treating team were very respectful of the fact that I was a medical practitioner as well, and so they didn't assume knowledge, but they also didn't, take me back to basics. So if I wanted to know something, I would find out the information myself and then take my questions to them based on that. So medical databases. So, things like your PubMed style databases and places that I have access to up to date, but also, breast cancer websites. I didn't really go to them very much. I was offered My Journey, haven't really used that very much. I looked at it, but yeah, mostly research papers. I took in my information from day one. I had no difficulties understanding what was happening. I did go silent for a month while I processed that all. It took me a full month to process it all, get it straight in my head, and then start talking again. I was quite withdrawn. But in terms of information, it never really was difficult for me to take the information in and process that, because I think most of it was actually for me already there. I've had an excellent team, and I've really had no worries at all. They were very comfortable treating a medical practitioner. They were respectful, and across the board, there was never a time where I had a health practitioner of any sort who was less than lovely and helpful and kind. So I had an excellent experience. It has been a huge burden, but I was in a much better situation than I think probably the most of the people who are getting diagnosed. So I was, being a contractor, I was self-insured, and I had that up to date. I was only covered for my basic living expenses, but that was a lot to cover anyway, being a sole breadwinner. I did have a 4-month wait for it to kick in, which was difficult. And at this stage now, I'm still trying to make up ground. It will take me, probably at least 2 to 3 more years to make up some of that ground. And I have already been warned by my oncologist that I will never work the way that I used to work. And I do understand that. I've had a prolonged time off work, and my chances of going back after 2.5 years to what I was are basically zero, and I can accept that. But I do have a decent chance to get back to a reasonable amount of work, and fortunately, to a certain point, my insurance will supplement the income and until I get to a certain level. So yes, it's been difficult, but it's not been impossible. But I was very fortunate. I think, I was hooked up with the oncology psychiatrist very, very early. Being HER2 positive, I think, I tended to consider it in terms of historical data before we had Herceptin. So before we had the targeted therapy, that the dreadful outcomes that used to happen, it took me a little while to get my head around that, Herceptin had been a game changer, and that we're very, very good at treating HER2 positive cancers now. I had other things going on in my life at that time. That developed over the course of having my cancer treatment, which is so often the case. And so I was put onto an anti-anxiety medication, and I just continued counselling and the psychiatrist just to keep myself steady. And also, as soon as I was able to, and as COVID lockdowns permitted, I made use of whatever supports around me that I had. So that social connection was and is still a very important part of it. Well, I suppose as in any serious diagnosis of serious illness, you find out who is going to stick around and who is not. Yes, and as per the awful amount of marriage breakups during breast cancer treatment, I didn't end up being any different, but I think that is related to probably things that are pre-existing in a lot of relationships. So, yes, my life changed. It changed dramatically. I missed out on an enormous amount of time with my little boy, and the relationship did change there because he realised that I wasn't going to live forever, and so there was some anxiety around him that I'm still dealing with. I mean, look, I would love to see treatment develop so that we had no side effects, but realistically, we know that's not possible. I think I would like to see a focus put on which targeted therapy is going to give the highest chance of complete response. In terms of the approved medications when I was diagnosed, I may have chosen a different one to Herceptin if I had realised at the time that there was some better outcomes. So I think I would like to see, in terms of treatment, even oncologists, from the point of view of oncologists, I'm now seeing patients who are getting what I would probably consider a less than optimal regime at times, especially in the high risk cases. And I know on at least on one occasion I put forward a medication suggestion because I had a reaction to solvent-based paclitaxel, and was switched over to the albumin-bound. But my oncologist had not been updated that had been approved under Medicare, and it had only just happened. So, he was annoyed that he hadn't received an update. There is so much information for doctors to go through that I think targeting things that have changed and become available and specifically putting them through to oncologists and other treating providers, I think I'd like to see that happen. I would honestly say that the single most important thing that I can see that is missing is the focus on maintaining general condition. I believe very, very strongly that I would not have coped as well as I have if I didn't have access via my private health cover to exercise physiologists, physios, exercise regimes. We know that it helps you with side effects. We know that it helps you with your recovery. We know it helps you if you have physical activity to decrease the risk for recurrence. So I feel like it's very short-sighted to not include that automatically in cancer treatment. And the other thing, I suppose, is looking at some of the complementary therapies in terms of putting them forward as being something that might be a little bit more mainstream. So, for example, I take a high-dose melatonin because it has research behind it. And because it has research behind it, I think it's worth considering some of those options as well, and incorporating them into everyday practice, especially when they are a low-risk option. So that would be, and very much working with the patient rather than telling them what to do. In terms of the degree of disability that it causes during treatment, it becomes a bit of a chronic disease. So my experience is not that we have mostly 6 months of treatment and go back to work. And I have a skewed view of this because of being a doctor. But certainly in my cohort, we struggle to get back to keeping our houses tidy, keeping our, ourselves in some semblance of a routine. I think services for just day-to-day things like cleaning your house and doing your yard. There are some beautiful charities out there that can help you, but they are limited. But I think if these things are addressed, it gives people a better chance of getting back to what they were doing. I certainly feel that if I had more support in that area, my ability to go back to work would have improved. So it's that very holistic. Let's look at what is being affected by, what mostly we struggle with, after breast cancer, the cognitive, the fogginess, the cognitive delay, the fatigue that we struggle with because we get so deconditioned. How do we alleviate those? How do we alleviate other pressures on ourselves in order to focus on getting those things back, so that we can go back to doing what we do, and that's caring for other people. I mean, if I went back now, I would say just put your head down and work your way through it. You'll find an end to this in one way or another, but that's stuff that you just have to go through. So no, I was well informed. I was as much as is possible well prepared, and very well looked after. So no, I don't believe that there is for me. I would say that we go through very aggressive treatment, and the best chance for us returning to life and becoming productive in such a way that our care is worthwhile, that there should be a look at the person as a whole and what their needs are as a whole, not just what their treatment needs are. So rehabilitation as a primary part of the HER2 or any breast cancer treatment, taking maintenance of quality of life, rehabilitation as primary goals as a part of treatment, rather than just treating the cancer, would be the thing that I would do, which is my point about having exercise programs as a mandatory part. Not everyone can afford them. It's horrifically expensive to go to an EP or a physio twice a week. Even on a mental health plan, 10 sessions is not going to be 5 sessions a year is not going to be enough during your treatment. So that my personal thing that I would put forward is you need to be considering general health and rehabilitation as a primary part of treatment.